Spinal cord is the lower part of the central nervous system. Our central nervous system has got two parts, brain and spinal cord. So it is a lower part of CNS. It's a tube of neural tissue which is continuous with the medulla oblongata at the base of the brain, and it extends till the lower border of L1 vertebra in case of adult. Okay, so this is an important point. So if somebody asks you from where spinal cord start and where it ends, this is the answer. It starts at the base of the brain, exactly, to be very precise, at the level of foramen magnum, because below than that foramen magnum level, we call it spinal cord. Above than that, we call it medulla. And in case of adult, it reaches to the lower border of L1 vertebra. In children, it may be even lower than that. It may be even lower than that. Sometimes it may reach to L3 vertebra also. Now, what is the important point regarding this lower extent or lower level of spinal cord?
Lumbar
What?
puncture.
Lumbar puncture.
Lumbar
Exactly.
puncture, we put needle at L4 and L5 junction.
Very good. Excellent. That's what I'm trying to explain here. Very good. So when you do lumbar puncture, you should be very careful. Do not go very higher. Okay. Do not go very high. Try to find out the L3, okay, and L4 junction by palpating the upper level or upper border of iliac crest, and then do it there. Do not go very high, especially in children. You may may damage the spinal cord if you go higher. Very important anatomy. The spinal cord is thicker at the neck and end of the cord. That means it is thick at the cervical and lumbar area, because from the cervical area brachial plexus arises, and from the lumbar area lumbosacral plexus arises. So as a result of this, these two areas are relatively thicker than the other part of the spinal cord. Quite an easy reason. And the main function of the spinal cord is to transmit the messages to and from the brain and to serve as a reflex center. If we take a cut section of the spinal cord, just like the brain, it also has got two parts, gray matter and white matter. Now, white matter means it is formed by axon, and these axons are covered by myelin sheath. That's why they look white. That's the reason. And another is a gray matter. Gray matter means these are collection of the neuron or cell body. But if we take a cross section in the spinal cord, the outer part is formed by white matter and the inner part is formed by gray matter. If we take a cross section of the brain, exactly opposite thing is present there. White matter is present outside and gray matter is present outside and white matter is present inside in case of brain. But in spinal cord, white matter is outside, gray matter is inside. Okay, don't forget that. Now, all of you, please focus on this picture. This is a real one, during the dissection. This picture was taken. You see this? This is spinal cord right at the center. There is the spinal cord. These are called spinal root. Okay, these spinal roots are combining together to form. See this. This is the spinal nerve. Spinal nerve. Okay, so spinal cord, spinal roots, and spinal nerve, and these are the different vertebrae. Just like brain, the spinal cord is also surrounded by meninges. And we all know there are three layers of the meninges: dura mater, arachnoid matter, and the pia mater. So dura mater is outside, arachnoid is in the middle, pia is inner one. In between the arachnoid and the pia mater, there is subarachnoid space. So what is present in that subarachnoid space around the spinal cord? What is present there?
CSF fluid.
CSF.
Exactly. There is a fluid which is known as cerebrospinal fluid. It's the same fluid which circulates around the brain also, and it is the same fluid which is present inside the ventricle as well. So remember that it's a very important, anatomy as well as physiological point for you. If there is any infection enters into the subarachnoid space, it can go anywhere all around the brain, even it can reach into the ventricle or around the spinal cord. Now, spinal cord terminate in a cone-shaped structure which is known as the conus medullaris. This is the terminal part of the spinal cord, and from that conus medullaris, one fibrous extension of the pia mater is extending downwards. We call that phylum terminal. Phylum terminal. Okay, so let me underline these things. These are very important point for you. Phylum terminal. This is a fibrous extension of the pia mater, and it extends to the posterior surface of the coccygeal vertebra. And the main functions of this phylum terminal is supportive function. That means it anchor the spinal cord onto the coccygeal vertebra. Okay, it fixes spinal cord there. Understand like this. We know what is conus medullaris now. One of the very important point here, please pay attention. The spinal cord doesn't extend the entire length of the vertebral column. Now, if we go into the detail of this vertebral column, there are cervical vertebra, thoracic vertebra, lumbar vertebra, sacral vertebra, and coccygeal vertebra. Okay, these are the different types. But just now what we told, the lower level of the spinal cord ends at L1 vertebra. But still there are lots of other vertebra left, isn't it? So very easy to understand. The spinal cord doesn't extend the entire length of the vertebral column. So a group of nerves leaves the inferior spinal cord and extend downward. And this group of nerve fiber is known as cauda equina. Cauda equina, because it resembles a horse tail, or it looks like a horse tail appearance. So it is known as cauda equina. So let me make it easy for you. Spinal cord ends at the inferior, border of L1 vertebra, and beyond that or inferior to that area, we have cauda equina present. Let's move on. Now look at this picture. This is known as cauda equina. Okay, horse tail like appearance. Cauda equina. Please mute yourself. Okay. Now, how many pairs of the spinal nerves are coming out from the spinal cord? See this very important question in the exam. There are 31 pairs of the spinal nerve. How many pairs of cranial nerve we have? How many pairs?
12
Cranial
pairs
nerve.
of cranial nerve.
12
12 pairs.
pairs. 12 pairs. 12
Exactly. You're absolutely correct. There are 12 pairs. Okay, 12 pairs of the cranial nerve and 31
in
pairs
number.
of spinal nerves. So 12 pairs of the cranial nerve and 31 pairs of the spinal nerve. Absolutely correct. So these 31 pairs of the spinal nerve attach to the cord by roots, and they exit from the vertebral canal via the intervertebral foramina. And at this region, we call them spinal nerve. Okay, we call them spinal nerve. So you can clearly see here, this is the cervical enlargement of the spinal cord. Okay, this is the length of the spinal cord here. This is known as cauda equina. Okay, cauda equina. Phylum terminal is the extension of the pia mater. This is known as conus medullaris, and here is the lumbar enlargement. Okay, everything is shown together. Now, one of the very important concepts, okay, before we go for the break is, please pay attention here. This is very important point. As the spinal cord is much shorter than the length of the vertebral column, the spinal segment do not lie opposite the corresponding vertebra. So let me repeat the same thing again. Spinal cord ends at L1 vertebra. So the spinal segment do not lie opposite the corresponding vertebra, especially when we go distal region of the cord. So in the cervical region, see here, in the cervical region, there is a difference of one segment. In the upper thoracic region, there is a difference of two segment, and in the lower thoracic region, there is a difference of three segment. This is an important point. You can clearly see here in the picture. You see this. This is a cervical, region or cervical part. You see this? Okay. So these are the different spinal nerves which are coming out from the respected vertebra. So already the C8 spinal nerve is coming from the lower part of C7 vertebra. So already I can see there is a difference of one segment. Now in the upper thoracic region, there is a difference of two segment. Okay. And in the lower thoracic region, there is a difference of three segment. So this is the important point. Okay. Now see here, before we go for the break, okay, let me explain one of the very important point for you, how a spinal nerve is formed. Though I'm sure many students know this already. About how spinal nerve is formed. Okay, how spinal nerve is formed. So please pay attention. This is a very important question your teacher will ask you. Though you have, I'm sure many students already know this. Okay, so let's talk about it. This is a cross section of the spinal cord. You can clearly see. Now the posterior part, okay, of the spinal cord is for the sensory aspect, and the anterior part is for the motor aspect, and the lateral part, especially thoracolumbar region, the lateral part is for which nerve comes out from the lateral horn of the spinal cord in thoracolumbar area? Which nerve?
Sir, autonomic nervous system maybe.
Absolutely. It is sympathetic neuron, sympathetic nerve. Okay, sympathetic nerve originates from the lateral horn of the spinal cord from thoracolumbar area. Very nice. Now let's focus here for the time being. So this is the posterior horn. This is the anterior horn. Okay, anterior horn is for the motor neuron. Posterior horn is for the sensory neuron. There is a dorsal root ganglion, and dorsal root ganglion is only for the sensory nerves. Okay, motor nerve doesn't arises or contribute to the formation of dorsal root ganglion. Whenever the dorsal root and ventral root combine with each other, then a spinal nerve is formed. So this is a spinal nerve. You can clearly see here. This spinal nerve will immediately divide into two branches, and those are known as ventral ramus and the dorsal ramus. Ventral ramus and the dorsal ramus. Ventral ramus will contribute in the formation of different plexus like brachial plexus and lumbosacral plexus. Okay, and the dorsal ramus, it doesn't contribute in the formation of plexus, rather it will go on the posterior part of our body and supply muscles and skin there. So this is in a very summarized way, a bit discussion about spinal nerve, how it is formed and what happens to it. Now you may be wondering what is the meaning of these terms like SS, VS, VM and SM. Okay, very easy. SS is somatosensory, somatosensory. VS is visceral sensory, VM visceral motor, and SM somatomotor. Now, somato means outer part of the body. Visceral means inner part of the body. And every student knows what is the meaning of sensory and motor. Sensory always takes sensation towards the spinal cord, and motor takes the command away from the spinal cord. Okay, so this much information will be enough here. Now, after this, let's talk about what are the tracts present in the spinal cord. Now, if we take a cross section of the spinal cord, some of the tracts are going upward and some of the tracts are descending downward. So we call them descending tract and ascending tract. So tracts are a collection of nerve fiber that connect two masses of the gray matter within the central nervous system. Okay, so this is the collection of nerve fiber, means collection of the axons which connect two masses of the gray matter within the central nervous system. Now, just take an example of corticospinal tract. So, which two masses of the gray matter are connected by this? Who can answer this? Yes?
Sir, the cerebral cortex and the anterior horn.
Very good.
Cerebral cortex and anterior horn.
Good. I got your answer. Excellent. So, see there, that is the meaning of two masses of the gray matter, cerebral cortex in the upper part and anterior horn cell in the lower part, corticospinal tract or fiber. They are either ascending or descending, and some tracts are called fasciculi or lemnisci. According to the different location, the different names have been given. Fasciculus and lemnisci. Fasciculus gracilis and fasciculus cuneatus is a very a familiar name for us, and they are present on the posterior part of the spinal cord. Okay, so they are also the bundle of white matter. Lemnisci, medial lemniscus, okay, lateral lemniscus, spinal lemniscus. There are different terms there. They are also the bundle of white matter or the bundle of axon. Now let's name some of the descending tract which are more important than the other. So we divide them roughly into the pyramidal system and extrapyramidal system. So pyramidal tract or pyramidal system means corticospinal tract, and it is again divided into two parts: lateral corticospinal tract and the anterior corticospinal tract. Now let's talk a little bit about this. From the brain or from the cerebral cortex, the corticospinal tract starts. Okay, it descends as a corona radiata. Then it enters into the internal capsule in the posterior limb of the internal capsule. Then it enters into the brainstem. There are three parts of the brainstem: midbrain, pons, and the medulla. Okay, when it comes in the lower part of the medulla, there is an area known as pyramid. In that pyramid, it will decussate or crosses over and go to the opposite side, and that's how it forms lateral corticospinal tract. So never forget this. Lateral corticospinal tract means crossover fiber, and anterior corticospinal tract means these fiber do not cross over, they just descend like that distally. Okay, so lateral lies in the lateral funiculus of the spinal cord, and anterior lies in the anterior funiculus of the spinal cord. Funiculus is that area which is covered by white matter. We'll talk about that when we see the cross section again. The extrapyramidal tracts are rubrospinal tract, reticulospinal tract, olivospinal tract, vestibulospinal tract, and tectospinal tract. Now, the name themselves explain that. Rubro is the red nucleus. Okay, rubro comes from the red nucleus. And you all know, where is that red nucleus located? In the last class, we talked about this. Yes? Where?
Sir, midbrain.
In the
Midbrain.
midbrain, sir. In the midbrain.
Midbrain.
Exactly,
Midbrain.
exactly. It is present in the midbrain. So it is one of the component of extrapyramidal system. Reticular formation. It is present in the central part of the brainstem. Okay, we call them reticular formation. Olivospinal, inferior olivary nucleus. Okay, again present in the brainstem, mainly in the upper part of the medulla. Vestibulospinal tract, vestibular nucleus. Remember the eighth cranial nerve, okay, that is known as vestibulocochlear nerve. So vestibular division of the eighth cranial nerve arises from the vestibular nuclei. And tecto, okay, tecto, tectum is also part of midbrain, tectum. So tectospinal tract. So these are the different examples. So before we move further, all of you, please focus on this picture. I'm sure all of you can see it quite nicely. So see here now. So these are the tracts which are present in the spinal cord. The red one are the motor or descending tract, and the blue one are the ascending or the sensory tract. Okay, so let's start with the motor and then go to the sensory. See this pyramidal tract, you can see clearly here. The lateral corticospinal tract is present in the lateral funiculus. The anterior corticospinal is present in the anterior funiculus. It is present here. This is anterior, and here is the lateral. If you pay attention, this is important one. When we examine the patient, this point is so important. See that the cervical fibers are present in the innermost area, and the sacral fibers are present in the outermost area there. Okay, so accordingly, if there is a big mass present right here, for example, that mass will compress the cervical fiber first, cervical fibers first. As a result of that, the weakness may start there in the beginning. This is called applied anatomy. Whenever you study anatomy, always think like this. Then only the clinical, medicine would be easier for you. Okay, don't simply study anatomy and try to correlate later. Correlate right there, because you are at this stage now. Extrapyramidal tract means rubro, reticulo, olivo, and vestibulo. They are present, by the red color. Now, what about the sensory or ascending tracts? The most important are three for us. Three important tract. One is called dorsal column tract, which is present right there. You can clearly see here. Dorsal column tract, also known as posterior column tract, present in the posterior funiculus of the spinal cord. And here the cervical fibers are outermost, and the sacral fibers are the innermost, exactly opposite to the pyramidal tract. So if there is a big tumor which is growing from the central part of the spinal cord, it will compress the sacral fiber first. Whereas if there is a tumor which is compressing the spinal cord from outside, probably the cervical fibers are damaged first. So it depends on the situation. Another important ascending tract is called, see this area. Okay, this is known as spinothalamic tract. Spinothalamic tract. It is also again lateral and anterior. Lateral and anterior. So you can clearly see here. And then another one is called spinocerebellar tract. So these are the important one than the other. Let's move on. Now to name some other ascending tracts apart from those three important one. Lateral spinothalamic tract, already shown in the picture. Anterior, fasciculus gracilis and fasciculus cuneatus. These are dorsal column tract. Fasciculus gracilis is present medially. Fasciculus cuneatus is present laterally. Okay. So one small point for you. This G, okay, G is for leg, and leg fibers are present in the medial aspect rather than the upper limb fibers. So this is a simple way to remember the things here. Posterior spinocerebellar tract and anterior spinocerebellar tract are other parts. Spino-olivary and spinotectal are other. These are all the ascending tracts which are present in the spinal cord. Now, with this background anatomical knowledge, let's talk about some clinical aspect. What happens when spinal cord is compressed? How we identify those patients? What problems those patients will have, and what treatment we provide? Okay, so this is a general type of topic. Please pay attention. Acute spinal cord compression is one of the most common neurological emergency encountered in clinical practice. It is always considered a neurological emergency. So I should attend this patient immediately. If there is delay in the management, what will happen? If there is delay in the management of spinal cord compression, what will happen now?
Quadriplegia will
Paralysis
be
will occur.
paralyzed.
Exactly.
Paralysis of the lower limb.
Exactly. You're absolutely right. The spinal cord will lose its function because these are the permanent cells. The neurons are permanent cell. Once they die, they cannot regenerate again. So there will be a permanent type of damage, and all the functions of the spinal cord in that area would be gone. The person may suffer from paralysis. The person may suffer from sensory, problem. The person may also suffer from autonomic problem. So all things can happen there. Okay, it depends which site of the spinal cord is damaged. If it is damaged in the cervical area, all four limbs will be paralyzed. If it is paralyzed in the thoracic and lumbar area, then upper limbs are spared because brachial plexus is already coming out. Already the upper limbs are already innervated. So only the lower limbs are paralyzed, and that is known as paraplegia. Paraplegia. So all these things will be discussed later. Let's move on. A space occupying lesion within the spinal cord may damage the nerve tissue either directly by pressure or indirectly by interfering with the blood supply. So these are the two main pathophysiological mechanisms of spinal cord compression. One, direct pressure. Okay, direct pressure, and this is because of the pressure the nerves are damaged, and another one is because of the ischemia, which is also done by that mass. The early stages of the damage are reversible, but severely damaged neurons do not recover. Hence the importance of early diagnosis and the treatment. That's what I was discussing a little while earlier. Quick management has to be done, and that is only possible after the quick diagnosis. Okay, so if you pay attention in this class, at least you can diagnose what is the extent of spinal cord injury or damage here, and you can refer those patients, okay, somewhere else by giving some important treatment. Let's move on. Now, what are the causes of spinal cord compression? So please focus here. We have divided, these, causes of spinal cord into according to the different site, like vertebral, meninges, and spinal cord itself. If there are pathologies in the vertebra, remember spinal cord is present at the vertebral canal, at the central part of the vertebra. Okay, so if there are vertebral diseases, then there is a high chance of spinal cord compression, and this is the frequency. Almost 80% of the time, there is spinal cord compression in case of vertebral diseases. See there. Now, what are the common causes from the vertebral side? Trauma. Okay, trauma, vertebral fracture, vertebral. You know, it is known as the different terms are there. You have studied this in orthopedics already. Okay, what is the term we use if vertebra is fractured? What is that term? Anybody remember? What do we say that? What we have discussed in the orthopedics? Anybody? It is known as compression fracture. Okay, don't forget compression fracture of the vertebra, because once a vertebra is fractured, because of the body weight, because of the effect of the gravity, that area is severely compressed. This is known as compression fracture. Another important cause is intervertebral disc prolapse.
The intervertebral disc has two important components: annulus fibrosis or fibrosus and nucleus pulposus. Nucleus pulposus is present inside, and annulus fibrosus is a fibrous ring which is present at the boundary of the intervertebral disc. Now, what will happen? During the intervertebral disc, the nucleus pulposus part is prolapsed outside, and it is compressing, okay, some of the nerve as well as the spinal cord. Metastatic carcinoma is another important cause, and the metastasis may reach there from breast, prostate, and the bronchus. These are quite common than the other. And multiple myeloma is another malignancy which may originate right there. This is classified as a type of bone tumor. And even tuberculosis. Remember, Pott's spine, we say. Pott's spine is a type of bone and joint tuberculosis which is quite common in the vertebral area. All of these can lead to spinal cord compression. Okay. Now, after this, let's talk about another, which is meninges site as the causes. It is known as intradural extramedullary. Intradural means inside the dura mater, but outside the spinal cord, that particular region. Tumors like meningioma, neurofibroma, and metastasis again, lymphoma, and leukemia. All these are different forms of tumor, either benign or malignant, and they can damage the spinal cord. Epidural abscess can also give compression to the spinal cord and can cause the problem. Okay. Now, regarding the spinal cord pathology, this is intradural intramedullary. Okay. So see there again tumors like glioma, ependymoma, and metastasis. Glioma, ependymoma, and metastasis. These are the different tumors which may develop inside the spinal cord substances and can cause the problem. So, what is the take-home messages from the causes of spinal cord? The cause can be found according to the different site. It may be found in the vertebra, and it can compress the spinal cord from outside. It may be present in the meninges. Again, it is compressing from outside. Whereas the third important types of causes are spinal cord disease itself, and they can damage the cord from inside. Now, after this, let's talk about the symptoms and sign of spinal cord compression. So please pay attention here. Very good concept should be taken from this class. The first thing is pain, and this pain is called radicular pain. Okay, radicular pain. That means it is localized over the spine. It is localized over the spine or in a root distribution, which may be aggravated by coughing, sneezing, or straining. So these are the different things. So once again, this is a radicular pain which may develop there over the spine or in a root distribution. Now, before that, I want to ask about what do you mean by dermatome? What is a dermatome? Anyone?
Sir, which is supplied by single spinal
Supplied by single nerve root.
Part of the skin supplied by a single.
Supplied by single nerve root.
Very good. So many students are answering, and all of those are correct answer. This is a part of the skin which is supplied by single spinal segment or single spinal nerve, whatever. Okay, this is known as dermatome. So this is a dermatomal type of distribution, this pain, and this is aggravated by coughing, sneezing, or straining because there is increased pressure development inside the abdominal cavity, and which may aggravate the situation. Another type is a sensory problem, and these are paresthesia, numbness, or cold sensation, especially in the lower limbs, which spread proximally, often to a level on the trunk. So it's a very interesting condition. If a part of the spinal cord is damaged, then the area which is below than that level, only the sensory problem occurs there. Above that level, everything is fine or normal. And these sensory problems can be anything. It depends on which type of fibers are damaged there, isn't it? Because if we talk about the different tracts there, okay, different tracts, then there is dorsal column tract, there is spinothalamic tract, and they have got different function. That's why a different type of sensory loss may be there. Regarding the motor now, the person may complain about weakness of the limb, heaviness or stiffness of the limb, and most commonly legs are affected because usually the thoracolumbar part of the spinal cord is mainly damaged. So legs are mainly affected in case of spinal cord problem, and we call that paraparesis or paraplegia. So let me write that term here for you: paraparesis or paraplegia. Now, what is the difference between paraparesis and paraplegia? Are they same term or slight difference is there? Anybody?
Yes, sir.
Weakness is paraplegia and
Paraparesis is the
paralysis.
weakness of plegia is the paralysis.
Exactly.
Weakness and paraplegia paralysis.
Very good.
Paraparesis is the weakness or paraplegia is the paralysis.
Exactly. You're absolutely correct. Paraparesis is a partial paralysis, or you can say weakness, and paraplegia is a complete one. It's a dense type of paralysis. Okay, according to that grading, isn't it? According to that grading, which we have learned in the motor system examination, the paraplegia is a dense type of weakness rather than paraparesis. Excellent. Regarding the sphincter, disturbances, there may be urgency or hesitancy of micturition, which leads eventually to the urinary retention. The person cannot pass the urine. So these all are different problems. Now, what about the sign? Sign means when you are examining the patient, what physical finding you will get in the patient. Okay, very, very important concept. Please pay attention. The signs vary according to the level of the cord compression and the structure involved. So see this. And the structure involved. For example, if cervical part of the spinal cord is compressed, all four limbs are paralyzed. If C3, C4, and C5 level is affected, then even the diaphragm is paralyzed. So that is the meaning. There may be tenderness to percussion over the spine if there is vertebral disease, and this may be associated with a local kyphosis. A wonderful example I can provide here is Pott's spine or tuberculosis of the spine. There would be tenderness when I percuss that vertebra. Okay, when I percuss that vertebra, just simply press there or percuss there, the patient will complain pain. And if you examine properly, if there is already a compression fracture occurred, there is a local kyphosis development. Kyphosis is a bending of the vertebra backwards. Now, let's talk according to the site or the region or the level of the cord compression, what signs are present there. If the cervical part of the spinal cord is compressed above C5 level, then what will happen? See here. Okay. Upper motor neuron signs and sensory loss in all four limbs will be present. Diaphragm weakness is also seen there because of the involvement of phrenic nerve. I think no need of any discussion here because phrenic nerve originates from C3, C4, and C5. That's why there is diaphragm weakness, and this patient probably will land in the intensive care unit because of inability to breathe under mechanical ventilator. Otherwise, this patient will die. That is the importance of diaphragm weakness or paralysis. Upper motor neuron sign will appear in all four limbs, and sensory loss is also present in all four limbs. So this is a very serious type of spinal cord injury. If cervical part of the spinal cord is affected from C5 till the thoracic region of T11, now what will happen here? There is lower motor neuron sign and segmental sensory loss in the arms, and upper motor neuron signs in the leg. Now, why? LMN signs are present in the arms because brachial plexus is originated from C5, C6, C7, C8, and T1. This is the origin of the brachial plexus. And for the arms, they act as a lower motor neuron sign. But below than that damage area, upper motor sign, neuron signs would be present. Never forget this golden principle here. At the same time, the respiratory or intercostal muscles become weak because they are supplied from this part of the spinal cord. So again, there will be a slight problem in the breathing. Let's go distally. What happens if thoracic part of the spinal cord is damaged now? The thoracic cord, okay, there would be spastic paraplegia with a sensory level on the trunk. Now, spastic paraplegia means the tone is very high in the lower limb. That is called spasm of the muscle. Spasm of the muscle. Spasticity. You know the meaning. I've already explained that before. Paraplegia is a paralysis of the lower limbs. If conus medullaris is affected or damaged, okay, now there will be sacral loss of the sensation and extensor plantar response. Sacral loss of sensation and extensor plantar response. Now, extensor plantar response is also known as another term. What is that?
Babinski sign.
Babinski sign.
Very good.
Babinski sign.
Excellent. This is known as Babinski sign. Very good answer, Babinski sign. So Babinski sign is positive in this situation. Actually, it is positive in all upper motor neuron lesions, okay, all other types. Now, if chora equina is damaged, okay, if chora equina is damaged, then the problem occurs to those areas which are supplied by those fibers. So there would be only lower motor neuron signs by affecting the chora equina, because spinal cord is already over whenever we talk about chora equina. So only the lower motor neuron signs can be present. So this, I'm sure, will provide you the very good, concept regarding the disease of the spinal cord. Now, before we move on to the investigation of the spinal cord compression, okay, I want to utilize this time by asking what are the findings of upper motor neuron and lower motor neuron diseases. Once again, though I'm sure many other students know this, okay? So in UMN lesion, what are the characteristic feature? Yes? What happens in UMN?
Spasticity.
Increased tone, sir.
Okay,
Spasticity.
one is
Exacerbate
spasticity.
the reflex.
Okay, spasticity means
Exacerbate the
excessive,
reflexes.
exactly, excessive, tone of the muscles, spasticity. Then hyperreflexia, very good, hyperreflexia, okay, reflexia. Hyperreflexia is another important point there.
Babinski sign.
Babinski sign positive.
Very good. Then Babinski sign. Babinski sign is present in the UML lesion, and there would be paralysis. This paralysis is not as dense as lower motor neuron paralysis, but nevertheless there will be weakness. Okay, it is not as dense as lower motor neuron features. Whereas in the lower motor neuron, now see this, in the lower motor neuron problem, what will happen? So just go on, just go. Yes.
Flaccidity.
Hypotonia.
Flaccidity. Flaccidity.
First thing is flaccidity. Flaccidity.
Areflexia.
Okay, very good.
Loss of power. Loss
Very
of
good.
power.
Reflexes.
Okay. Then areflexia. Okay, reflexia. There is absence of the reflexes. Absolutely important point. Okay, there is severe loss of the power, which is paralysis. It is always dense than in the upper motor neuron lesion, and there is one very important feature known as fasciculation. Fasciculations, which is not present in upper motor neuron features. Fasciculations. Okay, and exactly, this is a fibrillation or twitching of the muscle fiber. And one of the important point, over a period of time, because of the loss of lower motor neuron, the muscle will get atrophied. Okay, the muscle will become atrophied. So let me write that also here. Atrophy of the muscles, very pronounced in lower motor neuron lesion, whereas in upper motor neuron lesion also there will be atrophy of the muscle, but we call that as a disuse atrophy. Disuse atrophy. So that's a slightly a bit of different types of terms. Now with this, okay, let's go into the investigation of spinal cord compression. All of you please pay attention here. Let's start with the very easy type of investigation, like plain X-ray of the spine. We routinely do this if we suspect some compression or some damage of the vertebra, some erosion of the vertebra, fracture of the vertebra. Okay, in every case we start with plain X-ray of the spine. Chest X-ray is an important type of investigation here. Can you correlate why chest X-ray is done in this case? Anybody? Why?
Because
Look,
TB is the
look
cause.
for tuberculosis.
Tuberculosis, bronchogenic carcinoma.
Good. Okay, these are the two important points. I already got the answer. One is tuberculosis, another is carcinoma. Excellent. Bronchogenic carcinoma is one of the common malignancy which metastasize to the vertebra. So to rule that out, I want to do chest X-ray. And second, tuberculosis, because pulmonary TB is the first, type of tuberculosis which developed in the body, and from there, the tuberculous organism will reaches to the other part. So chest X-ray is always a standard type of investigation in any case of tuberculosis. MRI of spine or myelography is very important test. MRI is very commonly done in case of spinal cord diseases. You already know that. And myelography, you inject a dye there, okay, in the subarachnoid space, and then take the MRI or even CT. CSF analysis can be done. CSF analysis in case of compression of the spinal cord, which is known as Freund syndrome. CSF analysis will give us a lot of important picture. You already know that albuminocytological dissociation may be present in Freund syndrome. CBC is important in case of infection like epidural abscesses. Okay, any infective etiology, it gives us important clue. And serum vitamin B12, one of the important differential diagnosis of spinal cord compression, known as subacute combined degeneration of the spinal cord. It is caused by vitamin B12 deficiency. Let's move on. Some of the elaboration on these investigation now. Plain X-ray may show bony destruction and soft tissue abnormalities and are an essential initial investigation. There's no doubt about it. We always like to do this, especially if the patient complains of pain there. If we find some, a tenderness during our examination, we like to start with plain X-ray. Other are chest X-ray, and we already gave the explanation for that, mainly for the diagnosis of tuberculosis and malignancy. Chest X-ray is an essential part of the investigation. The MRI is the investigation of choice. If they ask by giving different tests for you, just choose MRI of the spine as the investigation of choice, because this is concerning about spinal cord damage. Now, all of you, please focus on this X-ray here. Okay, see this? Look at this arrowed part. It's clearly shown there. This area, there's a severe damage of the spinal cord. Look at this gap. It is much larger than the usual gap. This gap is fine, but here this is bigger. Why this gap is bigger? Because of angulation of the vertebra. See, here is the acute angle formation. This is called kyphosis. Okay, kyphosis. Because of the compression fracture of this vertebra, all the problems have started. And this is one of the usual cause of spinal cord compression. Now, the disease which is responsible for that type of problem is probably the Pott's spine or tuberculosis of the spine. Another important test is CSF analysis, and this CSF analysis should be taken, okay, at the time of myelography, because myelography means you are injecting dye inside the subarachnoid space and then taking the radiological test. Please mute yourself. Now, when we do myelography, just at that moment, we can get some of the CSF and send to the lab. Okay, this is called CSF analysis. And because of prolonged spinal cord compression, okay, there is albuminocytological dissociation which is present. I already explained this point to you. That means normal cell count with a very elevated protein. This is known as albuminocytological dissociation. And this condition is known as Freund syndrome. Okay, Freund syndrome. Never forget this. This is also one of the differential diagnoses of Guillain-Barré syndrome because of this albuminocytological dissociation. Because of the prolonged blockage of the CSF circulation, the CSF may look slightly yellow as well. Needle biopsy is required prior to radiotherapy to establish the histological nature of the tumor. If tumor is suspected, what type of tumor is this? Is it benign or malignant? Is it a primary tumor or some other types of tumor? Okay, so we need to find out. Please do not scribble there. Okay, now regarding the treatment or the management, is the final part of this small topic. Actually, it depends on the cause. What is the cause of spinal cord compression? So accordingly we can manage, but there are some general management. So let me explain that general management in the beginning. So all of you please pay attention here. Trauma or road traffic accident or fall from a height is one of the commonest cause of spinal cord compression. During that time, what is our management? How we start? Okay, that is usually done by giving corticosteroid injection to the patient. Usually we give dexamethasone or triamcinolone or those type of injection. Now let me ask you, why that type of treatment is provided in a trauma case where we suspect spinal cord compression? Why?
Decrease inflammation.
To decrease the edema
Inflammatory.
chances. To decrease the edema chances.
Exactly, absolutely correct. To decrease the chance of inflammation or to decrease the chance of edema formation, so that there is decreased compression of the spinal cord, we can give this type of therapy. It may help, it may not help, but we should give it as soon as possible. Okay, now with this concept, let's enter. Treatment and prognosis depend on the nature of the underlying lesion. Benign tumor should be surgically excised. Good examples are meningioma, glioma, isn't it? Neurofibroma, all of these are benign tumor. If they are present, they should be surgically excised. And a good functional recovery can be expected unless a marked neurological deficit has developed before the diagnosis. Now remember, we are talking about the nerves. If a nerve is prolonged, if it's compressed for a prolonged period of time, then that nerve may die or already irreversibly damaged. After that, even if we excise the tumor, the patient will suffer because the damage has already been done. That's why early diagnosis and early treatment is very, very essential in the neurological involvement. Now, extradural compression due to malignancy is the most common cause of spinal cord compression in developed country. and has a poor prognosis. So what can we do there? Early diagnosis is important again here, and probably radiotherapy can be provided, so that tumor mass or the malignant mass of the tissue is decreased in size. That can be done. Let's move on. See there? Now, this is known as a surgical decompression. A surgical decompression may be appropriate in some patients, but has a similar outcome to the radiotherapy. Surgical decompression means removing the tumor mass, or if you cannot remove it completely, probably some part of the mass is removed, so that the pressure which is provided by that mass would disappear. This is known as surgical decompression. But the outcome would be similar to the radiotherapy. Spinal cord compression due to tuberculosis is common, especially in the developing countries, and it also requires surgical treatment if seen early. This is also known as surgical decompression. If that cold abscess is giving pressure to the spinal cord, if the kyphosis is giving, stretching the cord unnecessarily, we have to go for surgical treatment, because once the cord is damaged, it is damaged permanently. It is always followed by anti-tubercular treatment. Traumatic lesion of the vertebral column require specialized neurosurgical treatment. Especially the fixing of the vertebra should be done. And you are studying orthopedics side by side these days. If there is very bad looking fracture, then we can go for open reduction and internal fixation type of treatment. Open reduction and internal fixation. And at the same time, you can also do something regarding the spinal cord. Now, at the end of this topic, okay, I have included this slide, which is about the spinal cord hemisection. Now, can you tell me what is another term for spinal cord hemisection? What we call that?
Brown-Sequard syndrome.
Very good.
Syndrome.
Brown-Sequard syndrome. Okay, Brown-Sequard syndrome. So these are the important features of Brown-Sequard syndrome. So all of you, please pay attention here. Brown, okay, Sequard syndrome. Very familiar question in the exam. Brown-Sequard syndrome is called hemisection of the spinal cord. Now see here, what is happening? So this is a cross section of the spinal cord. You can clearly see, okay, the dorsal columns are present on the posterior aspect. Corticospinal tract, the major part of the corticospinal tract is called lateral, and it is present in the lateral funiculus, and spinothalamic tract are also present on the laterally. Isn't it? This is the one. So if a hemisection of the cord is damaged, all the things which are present here would be gone. Okay, they are damaged, but the tracts or the fiber which are present on the opposite sides are not damaged. This is very important one. And before you give the answer to the examiner, just remember one thing. The corticospinal fibers have already crossed at the level of medulla, and they are the descending fibers. So there is no more crossing over there. They don't cross over there. That is one important knowledge. Another one, the fibers which are present in the dorsal column tract are also not crossing at the spinal cord level. They cross way above at the region of medulla oblongata. So they move or ascend on the same side. But the fiber which are there in spinothalamic tract, they quickly or immediately cross over at that spinal level and ascend on the opposite half of the spinal cord. So as a result of this, the dorsal column signs and the motor loss are seen on the side of the damage, whereas loss of pain and temperature are seen on the opposite side of the lesion. This is the important feature of spinal cord hemisection or Brown-Sequard syndrome. I'm sure you got the concept now. And what may be the cause of this Brown-Sequard syndrome at the end? What may be the cause? Anyone?
Trauma.
Exactly. Trauma is the most common cause. There's no doubt about it. Trauma. And sometimes
Then
even the,
tumor.
exactly, even the tumor or some other compression may produce this type of problem. So don't be surprised if you get this type of question in your clinical problem solving question when we take the appropriate exams. Okay. So with this,